We have two fantastic speakers today. Our sub-Is over the last few months, we've had several, and we want to have an opportunity to give each of them credit for their hard work and an opportunity to present their work. Now, why don't we start with Matt Lee, who's visiting us from his home institution in Illinois, the Carle, Illinois College of Medicine. He's originally from North Carolina and then attended University of Pennsylvania, where he received his bachelor's in chemistry and a master's in biochemistry. He's done really quite a bit of research and focusing on structural biology and HIV vaccine design. He's done fantastic work, and he's had a clear focus on his future in translational medicine. Outside of school, he enjoys outdoor activities, hiking and skiing. He loves to see the topography change, which I think is not as robust in Illinois, and one of the opportunities he can enjoy in the Northeast. He also enjoys craft coffees and tea. We'll see if he introduces some of that into his lectures today. Matt, welcome. Thank you for taking the time to speak with us. You've done a great job on rotation.
Thank you so much, Dr. Hiddleman. Good morning, everyone. I'm really happy to have the opportunity to talk to you guys this morning about molecular treatment frontiers for renal cell carcinoma. So let's start with a brief overview of RCC. Every year in the US, there are about 76,000 new cases and 14,000 deaths due to RCC. Clear cell is the most common histologic subtype by far, comprising over 80% of kidney cancer. And within clear cell RCC, the vast majority have deletions in chromosome 3p, which famously contains the von Hippel-Lindau gene. We've made great strides in treating RCC. Looking at this graph built from the SEER database, between 1992 and 2018, even though the incidence of kidney cancer has increased, the death rate has actually decreased. 5-year survival has increased from 62% in 1996 to 76% in 2017. While these trends look very positive, let's see what happens when we stratify the data. In these graphs, also from the SEER database, we're looking at trends in 5-year survival rate based on year of diagnosis and stratified by stage of disease. Here we see that between 2004 and 2013, we have a small increase in survival for localized RCC, which was already pretty high to begin with. We've made huge gains in terms of local regional RCC, but when we look at advanced RCC with distant mets, the survival curve has essentially been flat. This represents a significant set of patients that haven't reaped the benefits of the treatment advances in the last few decades. 5-year survival for metastatic kidney cancer as recently as 2016 was only 13%. And furthermore, 16% of patients with kidney cancer are presenting with metastatic disease. So clearly, there's still a lot of work to be done in treating advanced RCC. And this is what motivated this talk. I was led to the question, what's on the horizon for the treatment of advanced RCC? So in this talk, I'll start with a brief overview of the molecular pathogenesis and mechanism of action of the commonly used drugs to treat RCC. Then I'll go over a selection of clinical trials that I think have the potential to change how we manage the disease. First, I'll discuss how existing drugs are being tested in the adjuvant and neoadjuvant settings, and then I'll move on to a novel first-in-class drug candidate for RCC. So on a very high level, the treatment options for RCC is that if we can get the cancer out, we go in and get the cancer out. If we can do it with a nephron-sparing partial nephrectomy, even better. But if curative surgery is not possible, systemic treatment is the treatment of choice. We can do cytoreductive nephrectomy in a carefully selected subset of patients, but that's a rabbit hole I won't go down today. The specific drug regimens used for RCC are beyond the scope of this talk, but I think it's interesting to see how these agents have changed over the years. In the so-called cytokine era in the early 90s, things like interleukin-2 and interferon alpha were the first to show any efficacy in treating RCC, which is famously chemo-resistant. But this is only in a very limited subset of patients and at the risk of severe systemic toxicity. In the 2000s, tyrosine kinase inhibitors and mTOR inhibitors brought us into the targeted therapy era. And then in the 2010s, checkpoint inhibitors brought us into the immunotherapy era. These agents have made significant progress in treating RCC, but in the present day, I think that the rate of new drug discovery has slowed. Current research mostly focuses on using previously discovered drugs in different settings or new combinations to try to eke out some more survival benefit. Now let's talk about the major pathways of oncogenesis in RCC and how our drugs target these pathways. I know I can get a headache looking at these molecular diagrams, so I'll simplify it down into three major pathways. The first is the mTOR pathway, which responds to extracellular stimuli to do things like increase protein translation, cell cycle progression, angiogenesis, etc. Drugs inhibiting this pathway include everolimus and temsirolimus. Next is the von Hippel-Lindau hypoxia-inducible factor pathway, famously associated with von Hippel-Lindau disease, but as we discussed in the beginning, is actually mutated in the vast majority of RCCs, even outside of von Hippel-Lindau disease. Among many other roles, this pathway responds to hypoxia by increasing the transcription of genes involved in angiogenesis and cell growth. Von Hippel-Lindau is a tumor suppressor that normally keeps this pathway in check. Despite how well studied it is, there actually aren't any FDA-approved drugs yet that target this pathway, but we'll come back to that later. Both the mTOR and the von Hippel-Lindau pathways cause the expressions of various growth factors, such as vascular endothelial growth factor, that stimulate tumor proliferation and angiogenesis via tyrosine kinase signaling cascades. This common downstream pathway represents the target of many of the most widely used RCC drugs, such as those targeting the growth factor receptor, like bevacizumab and lenvatinib, as well as those targeting the downstream tyrosine kinases, like sunitinib and sorafenib. And finally, let's briefly cover the mechanism of the checkpoint inhibitors. In normal physiologic conditions, checkpoint receptors on T cells, such as PD-1 and CTLA-4, act as car brakes on the immune system to prevent recognition of self-antigens and autoimmunity. Tumor cells using poorly defined mechanisms can induce immune exhaustion by signaling through these checkpoint receptors. Thus, if we disrupt the interaction between the tumor cell and the T cell, we can reverse this immune exhaustion and basically reinvigorate their immune response against the tumor. And that's what antibodies like pembrolizumab and ipilimumab seek to do, basically disrupt this inhibitory interaction. Okay, after all that basic science review, let's move on to the clinical side. We'll start with adjuvant therapy. And we can't talk about adjuvant therapy for RCC without talking about the S-TRAC trial, a trial in local regional high-risk RCC where patients are randomized to receive adjuvant sunitinib versus placebo after nephrectomy. This trial was significant because it was the first to show any benefit with adjuvant therapy. We see the survival curves here for disease-free survival diverging. And sunitinib was actually found to extend disease-free survival about 1.2 years. And based on this data, sunitinib received FDA approval for the treatment of RCC in the adjuvant setting. But if we look in the supplemental figures from this paper, we see some concerns. Here, we're looking at overall survival as opposed to disease-free survival. And overall survival is usually considered the gold standard metric for cancer studies. In contrast to the figure we saw in the last slide, these lines don't diverge, and indeed, there was no difference in overall survival in the two groups. This is already a huge red flag. And now let's look at the toxicity data. About 54% of patients in the sunitinib group had to interrupt their dosing regimens, and the majority of those were due to adverse events. Only 28% of patients in the placebo group needed dosing interruptions, and most of those were actually not due to adverse events. We see a similar trend in patients needing dose reductions. It goes on. 48% of patients in the sunitinib group had a grade 3 adverse event versus only 7% in the placebo group. 28% of patients in the sunitinib group had to actually discontinue treatment due to adverse events versus only 6% in the placebo group. And finally, patients in the sunitinib group reported a significantly lower health-related quality of life. So what's the final verdict on adjuvant sunitinib? Many urologists don't like giving it due to the lack of survival benefit and the significant toxicity. The European Association of Urology actually recommends against it in their treatment guidelines. So overall, it really didn't live up to its promise of changing the treatment landscape for RCC. So where does that leave us? The Keynote 564 trial is another phase 3 trial that made big news just last month when it released preliminary data showing a beneficial effect of adjuvant pembrolizumab. This trial was very similar to S-TRAC in structure, randomizing patients with intermediate to high recurrence risk, RCC, to pembrolizumab versus placebo after nephrectomy. And we can see from the preliminary disease-free survival data that at the 2-year mark, pembrolizumab conferred about a 9% survival benefit. Now, you might be wondering, is this going to be subjected to the same pitfalls as the S-TRAC trial? The upfront answer is that unfortunately it's too early to tell. The data I'm showing was just presented at the ASCO conference this past June, so we'll have to wait for the full data to be published to make definitive conclusions. But let's take a look at what's been released so far. This is the Kaplan-Meier curve for overall survival. And we can see that unlike what we saw for sunitinib, it does look like it's diverging. However, the issue here is just that not that many people have died. And it's hard to analyze the survival difference when the vast majority of patients are still alive. So while these initial results do look promising, longer follow-up is needed. In terms of adverse events, it seems like toxicity will still remain a concern. Grade 3 to 5 adverse events occurred in 32% of patients in the pembro group versus 18% of patients in the placebo group. And we can see that 190 patients in the pembro group had to discontinue the drug, many of which were due to adverse events. Only 130 patients in the placebo group had to discontinue the drug, but in that case, most of them were actually due to disease relapse. So it remains to be seen whether adjuvant pembrolizumab is able to confer a true survival benefit and whether that balances out with the potential toxicity and tolerability. And that's where we currently stand in terms of adjuvant therapy. So let's shift gears to the neoadjuvant setting. There's actually some really solid basic science evidence supporting the use of checkpoint inhibitors specifically in the neoadjuvant as opposed to the adjuvant setting. In a mouse model of metastatic breast cancer, neoadjuvant PD-1 blockade, the mechanism of drugs such as pembrolizumab, actually increased survival significantly more than adjuvant PD-1 blockade. We can see from this figure, the survival curve. Now on the far right, the neoadjuvant group, which received PD-1 blockade prior to tumor surgery, had a significantly higher survival compared to both the control group and the adjuvant group that only received PD-1 blockade after surgery. Now this paper actually went further, asking why this difference existed in the first place. We know that PD-1 blockade is supposed to disinhibit or stimulate the immune response. But to me, the highlight of this paper was the finding that neoadjuvant PD-1 blockade actually stimulated tumor-specific CD8 T cells to a much greater extent than adjuvant therapy. So if we look at this big peak here, this is the level of tumor-specific CD8 T cells, and this curve represents neoadjuvant PD-1 blockade, which was significantly greater than the curves on the bottom, representing the control group and adjuvant PD-1 blockade. Furthermore, this stimulation and immune response was durable. Even 107 days out from treatment, we still see elevated levels of these tumor-specific CD8 T cells. So the hypothesis here is that by having the tumor in situ when immunotherapy is given, there's more tumor antigen around for the immune system to respond to immune checkpoint inhibition. Now, does this theory hold up on the clinical side? We're still in the early stages, but phase 2 trials of neoadjuvant checkpoint inhibitors has already shown significant response rates in breast cancer, non-small cell lung cancer, and muscle-invasive bladder cancer. There's currently one phase 3 trial for neoadjuvant checkpoint inhibitors in RCC, the PROSPER trial. The PROSPER trial will include high-risk RCC patients with no previous treatment and randomized to either nephrectomy alone or nephrectomy plus perioperative nivolumab. Nivolumab is a PD-1 inhibitor with the same mechanism as pembrolizumab. In the intervention arm, patients will receive 1 cycle of nivolumab prior to nephrectomy and then another 9 cycles after nephrectomy. And again, the hypothesis here that in the adjuvant setting, seen in this panel on the left, if we give upfront surgery before immunotherapy, we'll end up with lower levels of PD-1 expression due to removal of the tumor antigen, and thus a lower response to PD-1 inhibitors after surgery. But in the neoadjuvant setting, shown on the panel on the right, if we prime the immune system with a checkpoint inhibitor while the tumor is still in place, we can stimulate the proliferation of tumor-specific T cells, and after we remove the tumor, we can continue to maintain this immune response after surgery with further immunotherapy. I'm really excited to see how this trial pans out. With my background in biochemistry, I really love it when basic science discoveries can translate into clinical advances. And finally, like I mentioned in the beginning, all of these adjuvant and neoadjuvant studies are using pre-existing drugs in new ways. We haven't actually had a novel drug class or RCC in quite a long time. So for my final treatment frontier, let's go back to our molecular diagram for a moment. I mentioned that we don't have an FDA-approved drug targeting the VHL-HIF pathway yet, but we do have one candidate in the pipeline called Belzutifan. Let's talk a little more about how this drug works. Normally, the VHL protein is part of a ubiquitin ligase complex that marks hypoxia-inducible factor for degradation under conditions of normoxia. But when the body senses hypoxia, VHL can no longer act on hypoxia-inducible factor, so hypoxia-inducible factor is free to dimerize, which forms an active transcription factor that upregulates genes like VEGF, erythropoietin, all of the genes that tumors love. And as we know, when VHL is knocked out, like in von Hippel-Lindau disease, this pathway is essentially in constant hypoxia mode. Belzutifan is a small molecule that actually prevents the dimerization of hypoxia-inducible factor, thereby knocking out that transcription factor and shutting down this pathway. Let's take a look at the early clinical data for Belzutifan. There have been 3 phase 2 trials reported so far, one with Belzutifan monotherapy, one in combination with a tyrosine kinase inhibitor, and the last one looking specifically at patients with RCC in the context of von Hippel-Lindau disease. If we look at the objective response rate, which corresponds to a greater than 30% reduction in tumor size, we see rates of 22 to 36%. But if we look at the disease control rate, which includes both a greater than 30% tumor shrinkage and patients who have stable disease, we're seeing rates in the 80s to 90s. The rate of grade 3 adverse events ranged from 13 to 60%. The most common ones were things like anemia and hypoxia, which is actually expected. Hypoxia-inducible factor normally responds to hypoxia to upregulate erythropoietin. Relatively few patients actually had to discontinue the drug due to adverse events. So a few key takeaways from this data. In these first 2 trials, these patients were heavily pretreated, meaning they've already failed multiple lines of systemic treatment. So even though the magnitude of tumor shrinkage wasn't huge, they're really at the end of the road, and the high rates of stable disease is already very promising. The average survival in the early 2010s for metastatic kidney cancer was 10 months. So if this drug can really push progression-free survival past the 1-year mark, that'll be a huge deal for these patients. Of course, none of these questions can be answered for sure without a phase 3 control trial. And based on the data of these phase 2 trials, the FDA actually granted priority review status to Belzutifan in March of this year for von Hippel-Lindau disease-associated RCC. But again, the mutation that this drug targets is present in the majority of all kidney cancers. And there are currently 3 ongoing phase 3 trials with Belzutifan. One with Belzutifan in combination with tyrosine kinase inhibitor, one with Belzutifan monotherapy, and the last one to see if the addition of Belzutifan to an existing combination treatment regimen will increase survival. And these are scheduled to finish between 2024 and 2026. In conclusion, let's summarize the 3 molecular frontiers covered in this talk and the key trials to keep an eye on. In the adjuvant world, clinical trials of adjuvant therapy in RCC have been disappointing so far, but initial data from the KEYNOTE-564 trial with adjuvant pembrolizumab actually looks pretty promising. So the full data should be scrutinized closely when it's published to see if there's a true survival benefit at an acceptable level of toxicity. And this trial is scheduled to finish in 2025. In the neoadjuvant setting, there's really strong basic science rationale for the use of checkpoint inhibitors in the neoadjuvant setting, and we'll await the results of the PROSPER trial to see if this pans out in clinical practice. This trial is scheduled to complete in 2023. And finally, Belzutifan represents the first in a novel class of hypoxia-inducible factor inhibitors that may be able to provide durable disease stabilization in heavily pretreated advanced RCC patients. There are 3 phase 3 trials currently underway to see if this becomes the newest class of systemic therapy for RCC. Thank you all so much for your attention. I'd like to especially thank Dr. Kenny for making this rotation possible for me, and also for guidance on this talk, as well as Dr. Liebman, who provided guidance on the talk and also helped review slides, and all the faculty, residents, staff at Yale Urology that have made this rotation such a fantastic and educational experience. Thank you so much, and I'll be happy to take any questions.
Matt, that was a fantastic job. We'll take a couple of minutes for questions, so we still have full time for James and as well as our speakers at the end. Maybe we can have one of the oncology folks weigh in on their experience.
Matt, this is Michael Liebman. I just want to say great job, very well presented. And I think that's a great summary of a pretty complex topic. And I think you raise an important point about how the pipeline is kind of constrained. We've really, sort of reaped the benefit of advancements in other disease states, which have kind of crossed over, like checkpoint inhibitors. Is there anything else in the pathway in terms of immuno-oncology which may be explored because RCC is highly immunogenic? Is there anything that is applied in other diseases like lung cancer that may be bear fruit in the future?
Yeah, so there are a couple of other kind of isolated phase 3 trials of novel agents that I kind of just left out for the sake of brevity. There's actually a phase 3 trial with a modified IL-2. So we're kind of circling full back to the beginning, basically using IL-2, but pegylating it in certain places. And the idea here is that by pegylating it, you can modify the targets of IL-2 so it has more on-target effects and less systemic toxicity. So there's, I think, a lone phase 3 trial on that could be interesting. When preparing for this talk, I was kind of looking into whether there are any advances in CAR T therapy, just because it's such a hot topic for kidney cancer specifically. But from what I've gathered, CAR T therapy right now for solid tumors, especially RCC, is still in the very early developing stages. So I don't think we'll see anything with that anytime soon.
Because I really think that seems to be where there's the most promise, because we can sort of leverage any improvements in other diseases that are going on. So I think that's going to be kind of one of the interesting questions coming in the future.
Yes, for sure.
All right, listen, Matt, that was a fantastic job. Thank you for presenting to the group. I think in the interest of time and just to make all the speakers get in, we're going to move on to James Nye. James is homegrown. He's one of our Yale students, and he's currently an MD, MBA candidate. He originally came from the Washington, D.C. suburbs. He has a strong connection to urology. Both his parents do research on prostate cancer, so he's been preparing for this most of his life. He did his undergraduate work out in the Bay Area at Stanford, graduated in 2015, and then spent 2 years before starting medical school working in healthcare consulting and global health nonprofit. And he's did quite a bit of research in the department. He's worked with many faculty, Liebman, Cavallo, Hess, Sprinkle, and he's going to hopefully do a great job in promoting our institution and a lot of his publications coming out. Outside of medicine, he likes to play basketball and he runs, and he's a budding amateur photographer. So we're excited to have him present today, and he's done a great job as well in his rotation. James, you want to take it away?
Thank you for the introduction, Dr. Hittleman, and thank you everyone for the opportunity to speak here today. I'll be presenting on prostate-specific membrane. All right, so I'll start with some background on background, and then I'll go into the data in primary staging, then in biochemical recurrence, and end with a discussion on cost and access for this new technology. Next slide. So prostate cancer is the most commonly diagnosed malignancy in men. Progress in treatment, though, has been held back by inaccurate staging and evaluation of treatment response. And a lot of this is attributable to the insufficient sensitivity and specificity of available imaging in detecting non-localized disease, which may lead to ineffective undertreatment or overtreatment. So for instance, in high-risk localized disease, the inability to define the extent of disease may have resulted in men receiving surgery when they would have been better off with local regional or systemic therapy. And this likely contributes to the 27 to 53% of men with recurrence at 10 years. In men with biochemical recurrence, localization of disease is important for treatment decisions and assessing response to systemic therapy, and it's difficult to do that well with conventional imaging. Next slide. So using radiotracers that target the prostate-specific membrane antigen, also known as PSMA, has a lot of promise in addressing these issues. PSMA is a membrane antigen that's overexpressed by a factor of 100 to 1,000 in prostate cancer, with even greater expression in higher stage, higher grade, castration-resistant, metastatic, and recurrent disease. And the biological function of PSMA is unclear, but it may have a transport function because it's internalized by endocytosis. And that's actually really valuable for diagnostics because it allows for really good targeting. So the clinical applications of it are not just in diagnostics where the data is very strong, but also potentially in therapeutics. And there's this emerging field known as theranostics, where particles that emit alpha or beta particles can be tagged to PSMA and localized to the tumor. But for today, I'll just focus the discussion on diagnostics. Next slide. So if we look at the data, PSMA targeting compounds are poised to become the dominant means by which prostate cancer is imaged. They are already widely used in Europe. And I just took this slide from a Grand Rounds in Urology talk. There's a lot of clinical evidence, as you can see, for the superiority of PSMA imaging to other imaging techniques. So compared to, just in summary, compared to conventional imaging, such as bone scan and CT, PSMA imaging more accurately demonstrates disease burden and distribution. It can detect and localize both nodal and distant metastatic lesions, especially earlier at low PSAs. And compared to other PET tracers such as choline and fluciclovine, PSMA-targeted agents have similar sensitivity, but offer higher specificity. And they function better at low PSA values. They can also detect smaller lesions as small as 2 millimeters, and they're indicated not only for biochemical recurrence like the other PET tracers, but also in newly diagnosed prostate cancer. Next slide. So based on the strength of the clinical data, the FDA has approved 2 tracers already, the gallium-68 back in December for institutional use at UCSF and UCLA. Both these institutions actually make it in-house, but other institutions can apply the FDA by an ANDA to make it themselves and use it in their facilities. But more recently, there was an approval of a PYL, PSMA PET tracer, and this is commercially available. It should be available, right now I think it's only available in the southeastern United States, but by the end of the year, it's expected to be available throughout the country. And these are 2 different types of PSMA tracers. The clinical efficacy is similar for both, but PYL has a longer half-life, so it's more amenable to scaling up production. Next slide. So with the availability of these in the US, the question comes up of how these should be used in clinical practice. And the guidelines right now are pretty vague. The data is clearly better with PSMA PET compared to other imaging modalities, but the AUA guidelines don't really delineate between the various PET tracers. They just say they can be utilized, fluciclovine, choline, and PSMA in patients with biochemical recurrence, essentially after failure of local therapy. And I'll get to why I think the guidelines are vague in a little bit. But in the absence of strong guidelines, examining the data may be helpful in informing clinical decisions. Next slide. So now I'd like to review the data for using PSMA imaging for primary staging. Next slide. So the strongest data from this comes from the PRO-PSMA study, which was published in Lancet this year. It was a phase 3 randomized controlled trial that took 302 patients with high-risk prostate cancer. And it compared the diagnostic performance of PSMA PET-CT and conventional imaging, which is bone scan and CT, in detecting nodal and distant metastases at 6 months. And PSMA imaging had better accuracy, sensitivity, and specificity compared to conventional imaging. And it also resulted in fewer, unclear equivocal results and led to higher frequency of changes in management compared to conventional imaging. And this was the first prospective study done in this. It validated a lot of retrospective work. And what essentially the implication is that using PSA imaging would prevent patients with metastases that are undetectable on conventional imaging from undergoing futile radical curative treatment. And therefore would allow for better selection of candidates with low metastatic burden for local regional treatment. So, this data is really interesting, but it also raises the question of what should be done with someone who has negative findings on conventional imaging, but has small volume metastatic disease on PSMA imaging. And I think this is the reason why the present guidelines are so vague on this. Even though there were management decisions that were changed as a result of the PSMA imaging in this trial, it's unclear what the mortality benefit of that will be, and we won't know that for quite some time. Next slide. So another pivotal trial was OSPREY, which used histopathological validation and led to the approval of PYL. This was actually a requirement by the FDA for approval in the States. So they took 252 high-risk patients in one of the cohorts undergoing radical prostatectomy and radical and pelvic lymph node dissection. And they compared that against the PSMA imaging. And it was found that there was a very high specificity of 98%, but the trial actually didn't meet the sensitivity endpoint. PSMA imaging only captured about 40% of the metastases. And this is part of that is just due to the unfair nature of the comparison. Essentially, you're comparing imaging to microscopic dissection and inspection of lymph nodes on pathology. So that's just not really going to be fair. But if you look at the comparison to conventional imaging of CT or MRI, the positive predictive value for PSMA imaging was 3 times higher for detecting pelvic nodal metastases. So there's another cohort in the study as well that looked at patients with suspected recurrent or metastatic disease. And essentially these patients didn't have any radiographic evidence on conventional imaging, but 58% of them were identified to have distant metastatic disease on PSMA imaging. Next slide. So PSMA imaging is clearly superior to bone scan and CT, but where it's less clear is with how it compares to multiparametric MRI. This is something that we use often at Yale. There have been several small studies on this, but there's really no clear consensus. I saw some studies that said PSMA imaging was better and some that said multiparametric imaging was better. But there is some data emerging that suggests that combining the two of them may actually improve local staging. As you can see in the receiver operator curve on the right, the combination of the two was able to detect more cancers than either alone. Next slide. So now jumping into the data on biochemical recurrence. So there was a prospective trial out of UCSF and UCLA with 635 men with biochemical recurrence after prostatectomy. And they found that PSMA imaging was able to detect about 75% of prostate cancer in patients with biochemical recurrence, with positivity increasing with increasing PSA. And it had a positive predictive value of 84 to 92%. So this is pretty, this was a first prospective study that validated a lot of retrospective work. And there's another interesting meta-analysis that looked at whether, PSA imaging could help target salvage lymph node dissection. And in that study, they found a positive predictive value anywhere from 0.7 to 0.93. So it seems like it would be beneficial in targeting removal of lymph nodes. Next slide. And following on that a bit, there's really interesting prospective data using PSMA imaging to target oligometastatic disease with stereotactic radiotherapy. So this came from the Oriole trial, which is just in phase 2. And essentially, it took 54 men with recurrent hormone-sensitive prostate cancer and 1 to 3 metastases detectable on conventional imaging. And this study started a few years ago, so this was before PSMA imaging was fully validated. But all the patients essentially underwent conventional imaging, and then they also underwent PSMA PET imaging, but the investigators were blinded to the results of the PSMA the imaging. And so what they found is that patients who got stereotactic treatment of oligometastatic disease had longer, were able to go longer without undergoing androgen deprivation therapy. But what was really interesting about this is when they examined patients who had all of their PSMA avid lesions targeted, they had even better outcomes than this cohort of patients. So, my understanding is that the treatment of oligometastatic disease in prostate cancer is fairly controversial, but this does offer patients the ability to avoid the adverse effects and potential health risks of androgen deprivation for as long as reasonable. Next slide. So, the data on this is pretty compelling, but the next question is whether this is economically justifiable. Next slide. And there are a few studies that would suggest that it is. So in the study on the left, it's the same group that ran the Australian PSMA trial for primary staging. And they found that PSMA imaging actually had a lower direct cost than bone scan and CT imaging. And part of this might be due to the fact that they make their own PSMA tracer in-house, but it ended up being cheaper. And so if it was cheaper and it had better diagnostic accuracy, it would not only be cheaper up front, but also down the road in terms of saved treatments and incorrect diagnosis. And while these are Australian numbers, the numbers do roughly line up with the costs at UCSF in terms of at least the production of the tracer. And then on the right, there's a USA study coming out of UCLA. They actually modeled the cost of using PSMA imaging in biochemical recurrence. And they built out a Markov model. And they found that it costs about $17,000 more to use PSMA imaging. But as a result of that, there is a gain of about 0.3 in quality adjusted life years. And with a threshold, and this results in a cost effectiveness ratio of about $60,000 per quality adjusted life year, which in the US, we typically have a threshold of about $100,000. So using that metric, this was considered cost effective. Next slide. So now that PSMA PET tracers are FDA approved, the next question is, are FDA approved, what are the options? So like I mentioned, in the top row, there's the gallium-68 tracers, which are approved at UCLA and UCSF, and other institutions can apply to get an ANDA to use it. The issues with using gallium is that it has a limited supply and a relatively short half-life. And this does potentially limit access. Only a few institutions really would have the resources to do this. The other possibility is to use the PYL tracers, which have a longer half-life and are more amenable to being scaled up, and they will be commercially available across the US soon. But the issue with these is that they will likely be more expensive. I unfortunately couldn't find any pricing data online. And there's also a few other things in the pipeline with a gallium-68 kit coming from Telix Pharmaceuticals. There's also a theranostic in the pipeline coming from Blue Earth. But next slide. So whenever there's a new technology in medicine, there's the question of equity. And PET imaging in other cancers has been shown to be a source of racial disparity. And PSMA imaging is no exception. So even in the trials, Black patients were shown to be 4 times less likely to receive PSMA imaging than F-18 flucyclovine. And part of this may be due to the trial design at UCSF. They used a cost recovery mechanism, which means that the patients or the insurance had to actually put up the upfront costs of generating the tracers. So that definitely contributed to some disparities there. This is just something to keep in mind as these come to market. Next slide. So I think the most important question for all of us here is how will patients at Yale access PSMA PET imaging? So it turns out Yale has a cyclotron. So potentially it could go down the ANDA pathway and get approval to be used at Yale and generated at Yale. And that would probably likely be the cheapest way for patients to get it. But my understanding of an ANDA is, while it's cheaper than a clinical trial, it still takes a long time and costs millions of dollars. I think the average for an ANDA is about 2 years. So it might make more sense for Yale to buy from Progenics, at least in the beginning. But we'll have to see on that. So next slide. Next slide. So in summary, there's pretty strong data on PSMA imaging for use in primary staging over conventional imaging. And the data in biochemical recurrence shows that it's potentially viable for targeting treatment, both recurrence and oligometastatic disease. And I think the questions remaining are how to utilize it with multiparametric MRI, whether it should be used on its own or in combination. And then the last questions are, how will this actually present at Yale when it becomes available? But I think all these questions will be answered, in the near future. So I think it'll be exciting to see that. So with that, I'll end my presentation. And I just want to say thank you to everyone. The last 7 weeks here have been really enjoyable. I want to thank you all for all the advice and teaching, and a special thank you to Dr. Liebman for his mentorship over this past year and for helping with these slides. I really learned a lot on this rotation. I'm really excited to be a future colleague. Thank you.
All right, James, another fantastic talk. Thank you. Both you guys did great jobs. We'll leave the questions open to the audience. Anyone have any questions for our speaker?
Hi, James. This is Preston Sprinkle. Thank you. It's a very great overview of PSMA. So just to answer some of those unanswered questions, we will be getting PYL. We are actually potentially getting it next month in August because we are one of the trial sites for OSPREY. We are well versed in using PYL, and they have. We should have early access to that pretty quickly. In terms of using the gallium-based PSMAs, we have applied for to be able to use those as part of the ANDA as well as on off-label. I think we were doing that before there was approval of PYL, and we actually had the approval to use that. We were just waiting to see if the funding was going to come through. So Yale is definitely on the forefront of using these agents, and we will probably have them a little earlier than most other places around the country. I think your commentary about, how do we actually utilize this and in terms of changing patient care is a great one. We're still trying to assess that. The data you showed is excellent, but it, as you mentioned, is early. So I think there still is a fair bit of concern of what is identifying these small lesions. Are those going to be clinically significant? And is changing our plan going to really make a difference? So I think there still are some areas to study that. I mean, do you have any thoughts about how you think we could or should evaluate that to see if the additional cost is going to be worth any clinical outcomes?
So I don't have too much experience in this, but I imagine doing sort of a Markov model would be interesting to model that. And then I think to do that, though, we'd have to see what the outcomes are for targeting these small lesions. I think there's some studies right now of even using local therapy to treat like metastatic disease with low burden, like doing surgery to remove the primary tumor. And I think that's actually had some positive results. So I think it potentially could be useful. Thinking about that, but yeah, I think just cost modeling. I'm just curious, do you know the cost of PYL at Yale?
So that's part of the issue, is none of the cost has been decided yet. So that's one of the things that's holding up the distribution. So we have the technical ability to use it now, but I think they're finalizing what all the cost infrastructure is going to be. So I don't know.
Interesting. Yeah, but I think going back to that UCLA study, they said anything less than $14,000 was cost effective for biochemical recurrence. So I think that could be a baseline to start, but yeah, not sure.
James, this is Michael Lietman. Great job. Congratulations on finishing the rotation also. What I wanted to say, that it's interesting to really frame this as a biomarker, right? As we move towards sort of complementary and companion biomarkers to help make decisions. And they are increasingly baked into the trials. And you wonder if there's really, that's the future as well. That all, any trial in the advanced or even localized disease state should incorporate imaging with the state-of-the-art agent to really help understand and guide questions of treatment allocation and utility of the momentum to move in that direction.
Sorry, you cut out at the last part. What was the question?
So the real question is, the role of PSMA or other imaging biomarkers to help guide decision-making in clinical trials, just like there are kind of increasingly the use of genomic classifiers in guiding treatment decision-making in trials like G minor. Is there kind of, I think that really is, I don't know if it's more of a comment or a question, but I think that's really where the next step is, to help guide questions of efficacy and cost effectiveness.
Yeah, I think that makes sense. All of our data is based on conventional imaging right now, so it's not really fair to apply, the learnings from that to what we would expect from this. So I think, yeah, I'm excited to see how that data pans out.
I think one of the ironies, though, is that these two are not really aligned, right? Because when trials get off the ground, who knows, by the time they're mature, we might have the new imaging agent, right? And so then you'll be using 10-year-old technology by the time the data is mature.
Yeah, definitely interesting. Yeah, I think the other PET tracers just came out like within the last 5 years too, or were FDA approved in the last 5 years.
Exactly, exactly right. So we were very excited about Axeman, and now we have got the next great thing.
James, David Hess here. I'm curious, Professor James, if there's any data from Progenics on survival data in the folks who actually were treated with all metastatic findings.
I don't think there was that. So that trial was just it was just in the phase 2. So I think they mostly looked at just time to being on androgen deprivation therapy. I think it still has some ways to go, and it wasn't the primary endpoint. So it was just like a sub-analysis a clever sub-analysis that they did.
No, I thought so. My understanding was, if they identified oligometastatic disease, and then we used targeted therapy for that. I thought that was one of the sub endpoints of the trial. Preston, you know better than me about this.
Are you talking about the theranostics trial?
No, it was part of the OSPREY. It was the PYL study. Because I know I had a patient that actually was identified of having all metastatic site and was treated with targeted radiation therapy. And I'm just curious to know if they have a cohort of people like that, and what's outcomes? Are they following these people?
Yeah, so those people are being followed. That data has not mature enough yet, and I'm not sure it ever will be. I mean, the number of patients that they evaluated, I think at the final numbers in the cohort B, James had it there. I don't know if you remember the topic, but it's about 100. Cohort B was not real large, and the trial is being powered for detection, not really follow-up, as James mentioned. So I don't know if I don't think they'll ever publish that. I think we'll be able to review it as part of the study center maybe, but I don't think they'll ever publish that data because it's not going to be powered adequately to say anything.
Listen, I want to thank everybody. This was a great conversation. We still have a little bit more to fill in at the end of the grand rounds today. James and Matt, great. I think that's going to conclude today's grand rounds. Thank you for coming to present and introduce this to us. Thank you, everybody, for joining us this morning.